Okay, we're live.
All right. Hello, Dr. Powden. My name is Nick Stassen. We're here for the part 2 of the clinical outcomes assignment, tools assessment. Uh, introduced myself already. Why don't we have everyone else go ahead and introduce themselves?
I'm Megan Fowler, DAT student.
I'm Beth Neal. I'm a PhD student in curriculum instruction and athletic training education.
I'm Shelby Watts, DAT student.
I'm Connor Burton, also a DAT student and a part of Group 5 for this assignment.
Okay, we'll be discussing our comparison matrix and what we found for our specific body parts. For mine, I did wrist and hand, and the outcome measures I used were the DASH, the quick DASH, and the patient-rated risk evaluation. And what I found was the DASH and the quick DASH were the most appropriate for my clinical setting, and they had the most overall encompassing components to it in terms of like aspects of mental health, how it affects their ADLs, any other problems. There was more components to the quick dash and the dash than the patient-rated risk evaluation. And what I found between the quick dash and the dash were that even though the quick dash was only 11 components, if I'm not mistaken, and the dash was 30, the repeatability and the internal consistency for the quick dash was as good as the dash itself. Anyone want to take a stab at theirs?
I'll go ahead. So I had the FAAM, the foot and ankle measure, and the FADI, the foot ankle disability index, and the CAIT, the chronic ankle instability, I think it was table. And with mine, each of these, I was supposed to be looking at ankle patient reported outcomes. Two of them also encompassed the foot, so they were kind of region-specific tools. And then with the CAIT, this was just for ankle instability, so it was more of a disease-specific outcome as opposed to a region-specific, but it still focused on ankle and chronic ankle instability. With these, I kind of found that I guess you could say each of them is appropriate as a ankle patient reported outcome. One of them, it kind of can be limiting with depending on the population because it's specific to a certain condition as opposed to a region of the body, which would be the CAIT. And then looking more at the FAAM and the FAID or the FADI, these have been found reliable validity and have good retest for the ankle, and then specifically with chronic ankle instability. And then looking at the foot and ankle measure, that was found to be encompassing with musculoskeletal disorders in general. The chronic ankle instability measure, that one was much shorter. So if you're looking for something based off how much time you have with the patient, that can be nice. It can be very simple for the patient to follow along with. But then the only downfall, like I just said, is it's kind of more disease specific. They all do a good job of looking at symptoms to some degree and also different activities. The FAAM and the FADI break down in different subscales, which you can then look at those to see kind of more symptom activities of daily living or sport. And then if you wanted to just do a comparison of like 100, kind of looking at the 100 percentile of those subscales instead of an overall tool measure, that's another thing that can be done as well. And another thing to consider depending on what setting we're working in is the ceiling effect. that these may have because they could have been validated population, so it's hard to tell just with high-level athletes whether or not there'll be a ceiling effect. It can be quite different than just the general population.
I had nerve injuries, and it was kind of hard to find specific numbers for some of the like reliability and validity for some of them. So I looked at the Pain Detect Questionnaire, or PDQ, Leeds Assessment of Neuropathic Symptoms and Signs, or LANS, and the Standardized Evaluation of Pain, or STEP. So the PDQ was basically a patient-rated outcome, just a short, quick questionnaire on a Likert scale for patients to fill out and complete. Would probably take 5 or 10 minutes, and easily accessible and easy to incorporate in any clinical setting. The LANS required you to have access to needles. So if you can get access to needles for one of the physical tests, then you could probably do that relatively easily. And then the STEP required you to have access to more like other tools like a Von Frey filament and brass bars to complete the physical tests. So although the STEP had the highest validity of the 3 tests, it probably isn't very easily incorporated into a standard clinical setting for an athletic trainer. So I was kind of torn on whether or not I would even try to use it because the instructions on scoring it were also not clear or really listed anywhere. So yeah, they were not, probably none of these would be used in an athletic training setting really. I would most likely refer for something like this if I couldn't figure it out on my own.
So I had stuff for osteoarthritis. I used the knee injury outcome score, which is known as the COOS, the rheumatoid arthritis and outcome scale, known as the RAOS, and then I used the Western Ontario and Mass Arthritis Index. And with mine, so the WOMAC was kind of different and kind of on its own, but the COOS kind of is the beginning of what I found for all outcomes for osteoarthritis patients. I did not find anything really that was like, okay, if you have osteoarthritis in your body, this is what we're going to do. Everything I found was very region specific, which I like that much because I know most patients are going to have issues within certain areas, but I thought like the RAOS would be, with it being rheumatoid arthritis, it would be a little bit in the body because that usually affects multiple joints for the patients. So the idea, if a patient has rheumatoid arthritis and you're trying to collect these outcomes, you could be doing a scale of like 3 or 4 different tests to get the whole different, like the whole body incorporated. And so that bothered me with feasibility some. But like I said, the COOS was probably my favorite. There's also another hip one that was formed from it. It had good statistics with it. I just didn't want to all from the same test. The RAOS also came from the COOS. One of the COOS is that there was a pediatric version that changed some of the wording. Can and will have patients with osteoarthritis in the traditional athletic setting. But I had to think a little bit more outside the box and think of more of like if I was in a physician's office, what would I be using? And so that's kind of how I went with it because most of them were geared toward patients of a little bit older patient group. Everything was really good as far as like reliability, validity, responsiveness. The one thing that I did, they were all within 5 to 10 minutes of a test. So when you first think about it, you're like, oh, 5 to 10 minutes, that's not really bad. But if you're having your patient complete these multiple times in a tradition, like, that's going to add up. I don't think we shouldn't use them was 42 questions, the Rayos was 42, and the WOMAC was only 24. But I made certain that every test I used for this assignment was downloadable, so anyone can just grab a paper and pen and be able to do it. So I kind of went that route with this assignment. And like I said, I really do think they're all on Likert scales, which are easy and appropriate, and they're really easy to scale for the clinician. I'm just kind of concerned about how specific they are and being able to, like I said, there's only the COOS for able to find anything else more geared toward the PEDS population.
All right, I did shoulder patient-related outcome measures. And so I looked at the DASH also, the shoulder pain and disability index, or the SPADI, and the Penn shoulder scale. It kind of became pretty obvious right away whenever I was looking at the SPADI that it is like, it's not at all appropriate for an athletic population, just because there's no questions at all pertaining to any activity level whatsoever. So the DASH and the Penn shoulder scale both had questions pertaining to athleticism and like throwing, stuff like that. So that kind of stuck out right away, that those were more appropriate for an athletic setting. All three of the tests had pretty good reliability and validity. The Penn shoulder scale had 41 items, so it takes like a little bit longer, but it had things that pertain to pain, like satisfaction of treatment and everything, and then function. So it was broken down into a couple different levels, which I think is sometimes can be easier to compartmentalize whenever, like when I was reading through it and thinking of it, well, if I were a patient, would this be easier to kind of break it down into those sections, which that's just my personal opinion. On the DASH, there were 38 items. And then the SPADI, there was only 13 items. They all use the Likert scale. The SPADI had like 1 to 10. So I thought that that might be a little more precise because there's more numbers there. The other ones were, well, the Penn shoulder scale only went 0 to 3 for function, and then 0 to 10 for pain. So it was kind of like all over the place, which that's kind of frustrating. But I kind of thought in terms of just the amount of time to sit down and actually take the test, I was leaning more towards the DASH, that I thought that would be pretty appropriate for an athletic setting where I'm at. Kids are in here trying to run to their next class, or they have events that they have to go to. So it kind of looked like that one would take the least amount of time. But I kind of thought Penn shoulder scale and the DASH were probably equally as beneficial. It's just that the DASH takes less time. I did have something, Beth, whenever I was looking at your scales, one of the things that kind of stood out a lot was on the pediatric COOS. The pictures, I think, are super beneficial. Like, I don't think it really matters if it's a pediatric population or if it is an adult population or middle age or elderly. Like, for them to see the pictures and then they don't have to ask the question, like, oh, well, what do you mean by if I can do this? Like, they see a picture right away.
I agree with you. I thought about that when I was looking at it. I think I would just use the pediatric one for any population.
Yeah, I completely agree. I love the pictures. I just hate that it was, like I said, it was pretty specific. I'm just pulled it up right now, and like, I mean, obviously we know it's all for lower extremity, but it's very much geared. Like, I wish we could like replicate this, and maybe it's out there and I just was unable to find it, but something for the upper extremity. But my only question is using it for age groups. Do you think we would need to like validate it for them, or how? I don't know. What are your guys' thoughts on it? Because I mean, it is validated for kids. It's not for adults. The same scale, just word different. I don't see a problem in that. I don't know what you guys
I didn't really see a problem with it either. I thought it was basically the exact same questions, just worded a little bit differently, making it easier for younger kids to understand.
And really, for that matter, kind of all of those tests, like reading over the questions for the pediatric version, it felt like, well, the readability of it and how the questions flowed together wasn't really too much different than any of the other tests that I read over. So I think it would just simply be a matter of relating the pediatric version to an adult population.
Yeah, and it's so easy to have changed it. I really don't know why it was only accessible for the knee. Maybe just because that's kind of more of an area that we've seen more pediatric injuries. But I would argue that I think the foot would have stuff too. There is, like I said, there is the hip one. Upper extremity stuff was awful to find. So I wanted to get, like, my plan when I originally did this was to find like a lower extremity and an upper extremity for osteoarthritis. Able to do anything. So.
Hey, if you don't mind, I want to re-hit on my outcomes again. I got flustered going first, and I sped through mine really quick. I mentioned that that it had a high reproducibility and a high ICC score with the dash and the quick dash, as well as the PRWE. But with all of these outcome measures, they're all super. They're short. The dash is fairly short. It's only 30 questions. The quick dash is 11 with 4 additional components, and then the PRWE is only 15 questions. These are all things that are increase the feasibility of applying these to our clinical practice. And even though the PRWE is not it's not the most appropriate for an athletic population, so like my population, it still has its questions that can be applied to an athletic population. There are no limitations on any of these outcomes when it's applied to any population. All of these are Likert scales, 1 to 5 for the quick dash and the dash, and then 1 to 10 for the PRWE. And they all had, the problem I had with validity is there was only a validity score I could find with the dash, and it was high with like a 0.84 or 0.82 to 0.84. And then with the quick dash and the PRWE, I had a hard time finding number scores for it. They just said it was high, which that doesn't mean anything unless they have like an actual number attached to that from what I've read. I mean, I could say that a test has a high validity, but that doesn't mean anything if there was no data to back that up. Yeah, these are all pretty appropriate, and I think these are all good at easily administered to any population that we would see.
I had another point I wanted to add to mine as well. The 3 measures that I looked at, none of them were really meant to be measured on a week-by-week basis. They're more meant to be used as tools to help guide your treatment path. So they're meant to differentiate between the type of pain, between nociceptive and neuropathic pain. So if your score is higher, for example, on the PDQ, the higher your score, the more likely it is that you have neuropathic pain. The lower it is, the more likely it is that it's nociceptive pain. So if you can determine that it's neuropathic pain, you can alter your treatment plan to treat more specifically instead of trying, different types of treatments that maybe are less specific to that type of pain.
So I think we kind of, with how we did this, we hit the first couple points of what was kind of in the assignment description of, are these tools appropriate for your setting? I think we all spoke on that. I think I'm going to jump to the third question if you guys don't mind, because we kind of were going in that way. Do you make more appropriate your patient setting, patient population, kind of however we want to go about this? For mine, like I said, the CUS, we all agreed with pictures was great for the pediatric population. Transitioning to PRN, and so that's going to be kind of high school and college age kids. So I definitely think that in rural Indiana, some of those pictures are going to be very beneficial. The one thing that I really didn't like I said, is that I couldn't find anything for the upper extremity. So we know that osteoarthritis can happen up in the upper extremity. So what am I supposed to do? I mean, I could clinically create my own, but I don't know how else to technically kind of make that more appropriate. So I don't know what you guys thought about your test and if there was anything else that's better.
I had a hard time finding anything that was better. I used the outcomes site that Dr. Powden provided us, and everything was non-athletic related. It was TBI, stroke, mental disorder, neurological disorder, all those things for the wrist and hand. And then I went outside of the website and look for other wrist and hand specific, region specific outcomes. But yeah, there wasn't a whole lot that I could find. And I was wondering, what would go into creating your own outcome measure? Would it be appropriate to develop your own based on things that you've seen in the clinic? Beth, I don't know if you've had any experience with that at all.
I haven't created like a whole tool, if that's what you're meaning, but I think with the assignment last week and kind of going through our SOAP notes, I realized that I have a very succinct pattern of like my SOAP notes, and I realized that they're all very kind of, I'm not saying I'm a documenter, but they're all in like the same order of how things go. And so with that, I think that's kind of in a way creating a problem, because they're all not all, but a lot of it is or clinical outcomes that I was getting, such as like range of motion or manual muscle testing and things like that. Like I slacked in some of the specific prompts that I should have been using. Biggest issue would be the validity and some way to ensure that this tool is doing what it thinks it is. I think that this probably could be a patient or like a practice-based research project though, like where maybe with you in your setting, you create a tool for something very specific, kind of pilot tested at your university or secondary school or wherever you're working, and then send it out. That would be my thought, but I saw, Megan, you were kind of nodding your head with that. Do you agree with what I said there?
Yeah, I think it would be really interesting to just like figure out a way to come up with some specific questions. I don't know. I think of, okay, well, there's some tools that are very much of, you can almost combine the two of them, but then to figure out measuring that validity and the reliability of that test, I think would probably be quite a challenge, or at least I think it would be quite a challenge. But I think it would be really interesting, maybe somehow combining a very specific outcome measure with a more generic one to really kind of get like the whole effect, more related to athlete specific.
And I just came back from NATA, and this was like a hot topic, and like every talk I went to somehow incorporated proms into it somehow, and which I think is tremendous. And you would hear the researchers talk about like the validity and getting more research out there, and then you would hear more clinically based athletic trainers be like, yeah, that's great, but am I able to use it in my everyday practice? And so I really hope that some of the researchers heard that and are thinking about questions like this, because another topic that came up in the keynote brought it up a lot was like, this kind of sucks with EMRs, but I know we just switched to Core AT where I'm at, and that is great because it annoys the heck out of you, like, oh, in your next problem if you're overdue. And so I think things like that should be coming more and more within the athletic training population. Connor, you were there. Connor and Shelby, did you guys hear some of that too?
Yeah, I actually presented research project that I did last summer during one of the PROM rapid fire sessions for the free com, and it was kind of cool to sit in on that and see how that was going. And then there were also a couple other different ones that were kind of specific as well. I just thought it was really neat how we've been kind of talking about all that these first 2 weeks, and then it seemed like they really hit home on outcomes and patient-reported outcomes this year at NATA, because it definitely was a lot more focused this year than Baltimore and St. Louis, I thought, from the 3 that I've gone to so far.
I unfortunately didn't get to go to very many talks because I served on a committee, so I was at the mercy of their schedule. But the 2 that I managed to get to yesterday were both talking about concussion and that link between concussions to CTE, because that's a hot topic right now as well. And I went up to some of the speakers that were from UNC Chapel Hill after their talk, and I asked them if there was if they had heard anything about someone creating an outcome measure for that link between concussions and CTE, because I just thought that, I mean, obviously it would take decades to get that figured out, but I just thought that that was an interesting thing. And they talked about other, measures as far as concussions go. So just if you can apply it to one thing, why not try to apply it to something even bigger that it's possibly related to?
Question for you guys who have used PROMs in your clinical practice. I'm a fresh out DAT student, so I don't have a whole lot of clinical experience on my own. With patient-rated outcomes, do you guys ever feel like implementing like longer ones, or even just implementing them every day, kind of disassociates yourself with the patient as far as like having them come up and have their nose in a phone or on a piece of paper, and it feels insincere. I've never experienced it myself because I've never really used PROMs, but I've always wondered if that is ever a problem for clinicians, feeling like they're being detached from their patient in a way.
I've only, I guess, used it really not in the clinical setting a whole lot, but outside of that research project that I did. I guess the first thought that came to my mind, Nick, after you proposed that question, just kind of brought me back to kind of what the keynote speaker also talked about, like what Beth had mentioned. And one of the topics that he brought up was like how athletic trainers, we get so like a personal relationship with our patients, just the way that we interact with them. And it almost makes me wonder, kind of thinking about that. And then this whole idea that you just mentioned about having like our patients put their face in a device and answer all these questions right off the bat or fill out a form. Like, I guess it's more of a devil's advocate thing. Like, is that going to take away some of that personal, I guess, bonding experience that we get with our patients? Because it's a lot more question and communication based, as opposed to like how doctors are, where they're just filling out a questionnaire the first part of your visit to the PCP. And like, kind of like the joke that the keynote made was, it's like the doctor's always trying to, or the physician's always trying to hide the form from you. Like, you're not allowed to see it, even though it's your own information, filling it out while you're answering the questions. It just kind of, I guess, more that, like I said, the devil's advocate thing. Like, is that going to have any kind of impact on the relationship that we have with our patients? I guess it might even be a cool research study to do, just to see, like, as we start to implement this more, does that relationship change at all?
Yeah, because I just feel like I obviously see the use for PROMs, and I see the benefit for them. But as someone who's never really experienced them, at least during a daily, like a G-Rock takes 2 seconds and it doesn't really do anything. I do it towards the end of the treatment, anyways. But I've always just wondered if that kind of affects the patient clinician relationship in any kind of way.
So I by no means have used many. I have used very limited in it, but when I have done them, I think it's how you do them. So like, if you just hand them to your patient and say, do these, and then I think that's where that disconnect's going to be, because 15 minutes filling this out, and yeah, you threw it in your office, like, are you going to do anything with it? I think that like the times that when I did it, I would then kind of go over it with the patient right after they kind of saw the benefit and the like, reminded them of the why. I think that's the biggest thing. And I think the disconnect could be there, but I think it's all in us and how we what I mean? Like, I don't think that gap has to be there unless we make it there.
I agree with that. And I think as long as you're focusing on that patient education aspect, then they're going to see the value in it as well. And also, if it is an online system that you're using, like I know Kathy Deringer was talking about a new app that's supposed to be coming out within the next few months that's supposed to help, I believe she said it was supposed to measure, is an outcome measure for ACL rehabilitation programs or something like that. And it's going to report all that information de-identified back to the NATA so that we can get some physical evidence from what's been used in the field and get it published, get numbers out there so we actually have evidence to use those different methods. So it makes it easier on the clinician, it seems like, as well as the patient, because if it's something that they can, you can explain it to them, and then maybe they don't have time to do it right then and there because they're rushing off to practice, or their mom's coming to pick them up in 5 minutes and they don't have time to get through it all, then it's something that maybe they can do on their own time if you've explained everything to them, and make yourself available to them for questions if they have any.
Yeah, I think kind of tying in, Beth, some of what you were saying, and same with Nick, that it's probably my biggest challenge whenever I think about incorporating patient-related outcomes into my practice is how can I go about doing that so that I'm doing it in still like a very personable way, that I'm not disconnecting from them. But then two, what do I do with the numbers and what do I do with that score once I'm done? Because if I'm just like collecting numbers for the hell of it, then cool, pat on the back. But I think it's really just about what in the world you're doing with it.
That was my biggest question when we first started this outcome class, was what do we do with the numbers? I think Dr. Games mentioned it in his week 1 video for us. What Shelby was talking about is reporting that to one centralized location and then gathering the results on these PROMs and these different outcome measures, and then pulling that data and then interpreting that into something that we can digest as an average without extensive research into PROMs and clinical outcomes. But yeah, what do we do with the numbers? That is my biggest question.
So now that we all kind of have been in the research, have looked at our things, do you think that the outcomes that you guys chose, that the authors did a good job in summarizing their findings of the research to ensure that it is appropriate and does what? I think with mine personally, I think it does. The WOMAC had the worst statistics with it, so that's what kind of made me a little bit hesitant about it. But with the COOS being the main other type of test, I feel very confident in using that within clinical practice to be a help with the diagnosis and continued treatment of osteoarthritis.
With mine, Megan, you can go ahead if you like. Okay, with mine, with the DASH and the quick DASH, they had a lot of the same articles about them. They were all kind of compiled by the same people, and I used a lot of articles for both because I want to make sure I got all the data that I could. But it was all pretty convincing. All the studies had shown very consistently high rated scores, and then there'd be like a weird outlier. One score was a moderate, but it never fell below poor. They were all excellent, with the exception of one moderate on like the ICC scores, and the internal consistency scores were all high. With the PWRE or PRWE, that was a difficult one because all the research articles that I found were all foreign. Like how they implemented that in Spain. There was one in China and then Japan. They all seem to be valid, and they seem to do to be consistent and to be high reliability. But I just found it interesting that it was only implemented. The articles I found were only implemented in foreign countries, and we didn't have anything in the U.S. on that outcome measure.
Yeah, I felt like my that mine were, I didn't, well, the Spady I didn't I didn't like that one at all, really. Even though the numbers were high, I don't really feel like it had any worth in the athletic training room. The dash versus the pen shoulder scale or pen shoulder score. I think there was a little bit more of some mental and societal part in there. I don't know what word I'm trying to find right now. But there was some influence of that on the scale versus the pen shoulder score. But I kind of felt like both of those, the numbers, the validity and the reliability of both of those were pretty high based on the numbers that I saw. So I think both of those would be applicable, more so the dash though.
I think with mine, they all did a pretty good job of being upfront and honest and saying what they were validated and found to be reliable with was true. Like with the CAIT, for example, like in the name it says chronic ankle instability, and they said right up front at the beginning, this is only being looked at for chronic ankle instability. It seemed like a little bit of a limiter because it is disease specific. And I guess going into it, just knowing like that I was given kind of the ankle as my topic, I was just kind of looking at it like, oh, I want to find something that's going to be inclusive to anything that has to do with the ankle. But I guess we can't always have big wishful thinking like that unless we want to go out and develop something like that on our own. Since I guess I didn't really have a whole lot to say about disliking and liking, because I think all three of them can be very useful. I just wanted to bring up that, going back to question 3, talking about if we have other, or if we came across other measures, or if we know of other outcome measures that we'd like to use. As I was going through the databases and through the literature, I came across an abstract for the SAFAS, which is Sport Athlete Foot and Ankle Score. I don't think that one's public because I couldn't find the tool anywhere and I wasn't able to get access to the full article. But I was able to read through the abstract, and it talked about how that one was validated and reliable with Olympic athletes and a general population, to establish that there was no ceiling effect at all, no matter how competitive the athlete population is. So when I saw that, I was like, oh, I want to get my hands on this outcome measure, but I think I spent like an hour trying to find it and never could. So then I ended up pulling one of the other ones that I found. So that was just kind of a bummer to see that there is something good out there like that we can use with the athletic population, but then I guess maybe it's not public information, or I just wasn't able to find it with my search that I was doing.
So like I said earlier, like I don't think I would really use any of these in the in my clinical practice. The PDQ specified that it was really only looking at patients with low back pain, and that's the population that it works best for. The STEP also said that low back pain was basically one of the only kind of injuries or symptoms that was looked at, whereas the LANS said it could be applied to any neural condition. The numbers weren't really there for the STEP, particularly for reliability, and none of them really specified responsiveness, like specific numbers. So I think a lot more research needs to be done on these three, as well as probably other neural tests, outcome measures, what have you.
So we've talked a lot about like implementing into clinical practice, and I don't know, I kind of have a question for you. I brought this up with one of my other friends that's not in this class, because so as you guys know, I'm transitioning into full-time teaching and then working PRN through probably about 10 to 15 high schools and a couple colleges in the Terre Haute, Wabash Valley region. And so I was trying to think about yay, this is great outcomes. Can I use these in PRN? And I don't know, I struggled with this fact because yeah, I can do it the one day I'm there, but I might not return to that school for 2 more months. So unless the people that are there working full time at the clinics are doing this too, I don't know that I want to spend my time or the patient's time doing a prom once to then never, I don't know, where do you find it on this? Or is like, I'm not saying I don't agree with this, but for my specific thing, and I know that my type of job is what other athletic trainers are doing. So like, what do we do in these situations? Do we have the hospital or the system that they're hired in mandate them, or how do we get working together for the good of our patients to care?
I think you can take that question one step further, and how does that work in the medical model? Because in that model, you're having clinicians rotate through patient populations, and it's not necessarily going to be the same clinician working with the patient each time. And you're going to track them in whatever documentation software you're using, but is it still going to? It's kind of going along with your question, PRN. Is it valid? Is it appropriate to still use the proms with different clinicians and different patients that you're going to be seeing throughout the whatever whatever they decide to do? I'm not sure how they would rotate and how that would go, but
I think one of the things we've kind of talked about, like the accessibility of the measure itself, and then also I think another thing to consider, Beth, and you kind of mentioned it, is what's the accessibility that we have to the patient. Like if we're only going to see them once a month, or if this is like the only time we're going to see them, depending on what kind of setting we're in, or if you're just looking at the medical model in general, going to see someone once, like how they're going to be, and then it just becomes a matter of other ways to either have the measure stay with the patient so that they could take it to whoever else they're seeing within that healthcare team or something of that nature. But I think that's also another thing to definitely consider is how often do we need to see our patient in order to make sure that we're being able to use these PROMs to the most of their ability.
Yeah, I think there's some of them, like Connor, I remember, yeah, the CAIT was more, well, that one was more like clinical diagnosis of chronic ankle instability, but at least it would provide some sort of outcome measure to figure out, or to lead you more to a diagnosis and maybe towards a better treatment plan rather than like how their care is. So maybe, Beth, that might be something like finding those outcome measures of sorts that can kind of lead you more, at least towards a better targeted plan rather than how the care is going overall, like over an extended period of time.
I agree with that, since that's kind of how all three of my measures were, just kind of more to guide you into the proper treatment plan versus actually tracking the progress of their care.
I think the overall answer to your question is just going to be, it's up to you if you feel like it's going to be appropriate to do patient or do proms with whatever population you're going to see that day, or whatever school or athlete you're going to see that day, because it's not going to be the same for you.
I jotted down another question as we were kind of working through the discussion. I think this kind of came up more towards the beginning though, but just hearing like everybody talk about the different values of their Likert scales. I know with mine, a lot of them were like 0 to 5, and then there were a couple that are 0 to 10. And I think I might have saw a couple that were like 0 to 6 or 0 to 4. And we talked, I think it was Megan that talked about liking that 0 to 10 scale because they can get really specific. But then I almost wonder, like, if giving them too many options, like if that's going to not necessarily take away time, but then are they thinking about it too much, or could it be even better just to have that 0 to 4, or do we need that specific number? I guess I was just curious to see what everybody's thoughts were on that, as far as how specific do we want to go, and how complex or how basic would we like this to be for our patients to make it easiest for them as well.
I think that might depend on your population, obviously. Being able to kind of read the maybe literacy level, the knowledge of the patient. If they, you know, are kind of, if you can get that vibe that they're more of like an apathetic and decisive type of person, then maybe a smaller scale with fewer options would be better for them. But if it's, you know, somebody like, let's say you're working with an athletic training student at an undergrad program and they're a basketball player or something, they have some more knowledge, so they might be, I don't know, better equipped to handle more options.
I think going along with what Shelby said is, you give, you know, they're indecisive, because I know when I filled out like applications for jobs and you have those Likert scales, and are you whatever, you're in between one, you're like, I'll give myself the better one. It's not, it may not be as accurate as you were hoping it to be, versus having a 0 to 10 or a 1 to 10 scale where you can get more precise in what they're actually experiencing.
I think for the most part that a lot of the ones that were like 0 to 10, like I think of the Spady, like I talked about before, that there were only 13 questions. And so I think really with all of these, even if they're looking at 0 to 10 versus like 0 to 4, 0 to 3, the amount of time that they're still spending on that and their ability to focus on the outcomes measures, I think that it's one, well, that's why other people have created it, because they've probably figured out that that is applicable. But two, I think like they're still able to focus the entire time on that, on what they're filling out for us.
So my first thought would geared more toward research, and I don't know that that's the right way to go, but it's just how my brain went. So like if you're trying to do statistics on research, the more options you have, the more places people can be spread out. And so depending on where you want the data to land for comparison, or even comparison patient to patient, for that same patient, like if you have so many options, is it going to make it harder to be like, oh, you moved from here to here to here, rather than like a less amount of options and they're a lot easier to see, or more people are clumped together, we can make better assumptions based on what we have. I know within a lot of the research I did for more of educational assessments, we only used a 4 or 5 point Likert scale to try to keep the population together. But I don't know. That's just my comparison. Mine is like, hey, if we have too many options, we're going to have people all over the world, and like trying to get this is going to be very hard.
Yeah, I think that's something that I didn't think about before. You're definitely more research oriented than I am, and I never would have thought of that. That makes more sense as far as comparing these outcome measures to other outcome measures and to themselves per patient.
Did anyone have anything else that they wanted to add about your outcomes, anyone else's outcomes, anything kind of on these realms?
Yeah, I got one final question. We'll go through all of us. Out of the 3 we picked, the number 1 we're going to go with.
I'll go, because for me it was easy. I'll use the Coos every time. Coos Peds if we want to get specific, because we all really like the pictures.
Okay, I'm going to use the dash.
I will also use the dash.
I still don't know that I would use any of them, but I think the PDQ kind of caught my attention the most as far as feasibility, because there's no really equipment or anything, training required for it, but it's only specific for people with low back pain.
I think of my 3, I probably would have gone with the foot and ankle disability index. I really would have liked to have seen the full article on the sport-specific one, but since I couldn't get access to it, I'll just have to go with the FADI.
Connor, I wonder if any of us were on a college, I don't know where you looked for it, but you know how sometimes like if you're on a college campus, you can get more access to it. Maybe we should see. I'll be up in Terre Haute sometime next week, so depending on how things go, I could maybe pop on campus and see if it's available. if you just want to send the link, the like acronym again, because I mean you said it, but I'm gonna forget it. Even within just the group message, I'll try and see if I'm able to access that or get it in from our interlibrary loans.
Did you try to access that through the library's website with your Sycamore login? So I know you can find most of every database. They're not all there, but most of them are there.
Yeah, I did log in through the website and then go through the databases that are available to us. The one I was able to get the most hits on it through Google Scholars, but then that just took me to another journal article or another journal website where I would have had to pay like $39 just for that one article. But then I couldn't get it through the school. So I didn't try interlibrary loans because I found it so late in the week. I didn't think I would get it in time. But I'll definitely put the article name in the chat or in our email group that we have going.
And if you ever send into interlibrary loan, they'll ask if it's really necessary. Just say yes if you want it. They just try to be cheap. So cool. Well, anyone else? Last thoughts? It was great talking to you guys, and we'll see you guys soon.